posing with the risk factor, or they really didn't go for screening and you didn't do the operation, what can happen to this dysplasia?
It might become malignant.
Very good. It can be converted to neoplasia. Clear?
Yes, it is.
What is the major difference between dysplasia and neoplasia?
Neoplasia is an abnormal growth, but dysplasia is just differentiation and maturation.
But reversible. If you remove the risk factor, like example, I don't know, in Malaysia, in villages, kampung people, they love to take betel, the green leaf and betel nuts. Our part of the world, like Pakistanis, Bangladeshi, Indian, old people, they love to take betel nuts and one leaf. This is their habit. And also tobacco. So what happening to tobacco? More people, they're taking cigarette smoking. Lung one day doesn't convert to malignant cell. Before that, the whole respiratory system, it go for dysplastic change. But what happened during the dysplastic changes, you'll be finding a lot of thick mucus secretion, decrease defensive function by the cilia, loss of cilia, patient will having vigorous coughing. So those are the changes actually from normal ciliated columnar to other type of cells. So when it is converted to other type of cells, it's going to lose its normal functionality. So if you advise that person, please stop smoking. So you cesarean or you are reducing the risk factor, then again it may can convert to normal cell. So although dysplasia still is a precancerous condition, but it can be reversible. But once it is converted to neoplastic changes, is it reversible or irreversible?
Irreversible.
Neoplasia is irreversible. So that's why whenever patient is changing the normal function of the body, it can be cervix, like very common in female is the cervical cancer. There are few risk factors are there. So patient will be telling you abnormal uterine bleeding, always feeling heaviness into the uterus, repeated coming, dysmenorrhea, painful, and repeated occurrence of menstrual period. So it means they're having the changing in the normal lining. So at that time, we have to take the precaution. If not, patient will go for metastatic or malignant changes. Okay, so we know the journey now. Normal cell can transform to a hypoplastic cell. Hypoplastic cell can transform to dysplastic, and dysplasia towards neoplasia, right? So I think all of you know what is the definition of cancer. Who can give me the definition of cancer from pathology? How you can define cancer? Any volunteer?
When the cells grow at an abnormal rate.
This becoming very simple.
Malignant neoplasm.
Have you got any definition from Robbins?
Malignant neoplasm.
In hospital, you cannot give this answer.
Abnormal growth of cell which proliferate uncontrolled.
Malignant neoplasm.
Okay, after the class, you refer back to pathology book and kindly please remember definition of cancer from the Robbins. Okay, but what you are saying is your concept. Probably it is not the exact definition. Now, why exact definition is important? It is actually important because a proper textbook definition really going to zip and summarize the whole disease process. You and me, ordinarily, we cannot define anything. Is the Robbins, they already defined something. So, say for example, if I'm asking you, how can you define apoptosis?
Programmed cell death.
Okay, technically it is correct, but is it the exact definition of Robbins?
Doctor, is cancer basically malignant neoplasm?
Sorry?
For cancer, is it like malignant neoplasm?
Yes.
So can that be considered as a definition?
No, that's why what I'm saying, each textbook for each of the events, they come up with one standard definition. You have to know it. What you are saying is your concept. Probably, definitely when you go to year three, SBIQ, all this portion going to be reduced significantly. Then it will be more on your skill, clinical skills, and also your SAQ capability will be judging more. So that's why I'm saying you have to bring transformation in your habit as well. So try to focus more on the textbook and read important characteristics and also definition from the textbook, which is very very important. At least 4 to 5 sentence one definition into the Robbins, and you have to remember it. But I agree, your concept is clear. You define cancer, you are saying there is a limitless replication and it is uncontrolled cellular growth. But if I'm saying about bone marrow, it is also doing the same thing. Am I correct?
Yes.
Because just now I think two students, Ayman and somebody else, also give me the definition. The cancer is characterized by or defined by uncontrolled or limitless cellular growth. Now I'm telling your bone marrow also going for limitless replication. So is it cancer?
No.
No.
So that's why clinician will catch you like that. Okay. Now, who can tell me 4 cardinal features of cancer?
Invasion.
Invasion.
Metastasis. Sorry.
Can you see this all in under microscope?
Yes.
I'll kill you. How can you see metastasis under microscope? I'm giving you a tissue. I got a patient. I'm taking biopsy from that patient, or I'm doing FNAC. Example, very common is the thyroid cancer. In some area, in female, you can see thyroid gland is enlarged. So you're not sure whether it is hyperthyroidism or it is thyroid malignancy. So what we do, this is very superficial. With a needle, we do the FNAC test. Following the FNAC, you are making your histological slide and you are going to observe under the microscope. So when you are observing a cells, a group of cells or a tissue under microscope, that time you have to decide whether it is benign or malignant. It starts from the stain color until the cellular characteristics. Who can answer me on that?
High nuclear to cytoplasm ratio.
Very good. So
Cytodifferentiation.
It means, yes, lack of differentiation means you'll be seeing suddenly one area is been different compared to other neighboring cells. With the FNAC, it's not likely you are taking all malignant cells. There'll be mix-up of cells. So you'll be seeing suddenly, like in Malaysia, if you go somewhere, you can really see who is local, who is foreigner. Am I correct? Correct or not?
Correct.
So all the local people, most likely they have some character similarity, facial similarity, and all that. Until you are not asking everybody's IC, right? Without IC also you can recognize by the morphology. So that morphology, please try to depend on the morphology. If anybody want to be a good clinician, good pathologist, you have to understand the morphology. So somebody was telling me the cell nuclear cytoplasm ratio is altered. Some morphology change. Is that correct?
Yes.
Is that correct? Okay. So change in cellular morphology, changes in the pleomorphism. Anything else?
Hyperchromatic nucleus.
Very good. Very, very good. As I said, she remember my clue. Even with the staining, with the normal cell and malignant cell, you can understand that. Because there are a lot of cells and they have always active cells. So what they do, they absorb a lot of dye. So they'll be more dense in color, hyperchromatic. With even H&E staining also you can see cancer cells are more deeper in color. So this is increasing your doubt. After that, somebody was telling me invasion, right?
Yeah.
Okay. So if you really get a good specimen, you'll be able to trace cell migrating. What will be the way of migration towards mucus or towards serous? Do you know what I mean?
Towards cells.
Okay. Very good. It's serous. In your screen, what you can see now? What is appearing actually in your screen in the desktop?
This
Round some
doctor,
profiles are there, right?
I can't see the slides.
No, there is no slide. I'm discussing without slide, right?
Yeah.
So you are saying invasion. So invasion is towards mucus or towards serous?
Towards serous.
Very good. Honestly, tell me how many of you don't understand it? Is there anybody? What he said now, you don't understand. How many of you are there? Nabil? Nabila?
Yes.
Okay,
Yes.
Nabil. So what does it mean? It means if you are coming towards mucus is good for body. Why? All mucus layer is draining into the lumen. It means body will secrete it. Actually, that is the normal body's defense mechanism. If any bacteria come, always cell propagate them, channel them towards the mucus. So if you can send them back out of the mucus, they will be in the lumen. In the lumen, whether it will be they going back outside or other defensive mechanism will be coming and attacking them. Whereas if they move towards serous, is dangerous. Why? Towards the serous, you have the blood vessels. You know, do you understand what I'm talking about?
Yes.
Yes. So towards the serous, outside layer, parietal layer, you have more lymphatics and more blood vessels. And they always love to go towards serous because they want more blood supply. Clear? So that's why if you have a very experienced eye, actually you can see the migration of the cell. It will be coming towards submucosa, external muscle layer, internal muscle layer, and towards serous. You need not to penetrate serous. Once you reach around the serous, it's already grade 2. Clear? Why it is so important for us? Because our cancer treatment model itself involving what is the stages of the cell. Is it only proliferating phase or already it started invasion? Our total management going to be changed. Clear? So I think all of you now understand what we really mean about the characteristics of cancer cell. There will be aggregation of the cell or rapid proliferation of the cell. Nuclear cytoplasm ratio is already altered, hyperchromatin cells, and also you can notice the movement towards the serous layer. After invasion, what will happen? What is the next?
Metastasis.
Very good. So now you understand the logic. Why it loves to go towards serous? Because to get the venous drainage and also to get extra nutrients. Okay, fine. Now, who can tell me the basic theory of carcinogenesis? How a normal cell can convert to cancer cell? What 4 major change occur?
Mutation in the gene.
Very good. Mutation in the gene. Okay, so what actually happened? There is a specific event occur.
Tumor progression.
Tumor?
Progression.
Okay, Lucky? Any other idea?
Failure of DNA repair.
Okay, so yeah,
Mutation.
correct. But
Mutation.
yeah, mutation actually what that mean?
Change.
Can you tell me what is proto-oncogene?
Growth promoting gene.
Yes. So after mutation, this proto-oncogene, a normal regulatory gene, convert to?
Oncogene.
Yes. Always you should say this is the principal etiology or actually hypothesis behind cancer. Mutation occur to convert your proto-oncogene towards oncogene. Once you have an oncogene, later on other three things will come. What are those? There will be inhibition of tumor suppressor gene, right?
Yes.
Okay. After that, what gonna happen with the programmed cell death? Stimulation or inhibition?
Inhibition of
Inhibition of
apoptosis.
programmed cell death. And every day, even with the UV rays, ultraviolet sun ray, your spicy food, all the time you are attacking DNA, right?
Yes.
Yeah. But we are lucky enough, our DNA repair gene is intact, right?
Yes.
So that we don't experience any cancer. So that's the main theory behind carcinogenesis. You need a mutation or a shoot up to convert your proto-oncogene to oncogene. Once you have a oncogene, it's going to prevent your three defensive function. Number one, it inhibit your tumor suppressor gene, it inhibit your programmed cell death, and also it inhibit your DNA repair gene. Is that clear?
Yes, doctor.
Okay. So why I'm saying I think each things have a direct correlation with the therapy, with the drugs we're going to select, right? So I think that is the principle occur. A lot of people are now trying actually the anti-cancer drug, very much focusing on how to own your apoptosis, how to stop your cell cycle. Did you remember last time when we were discussing about the drug, we talk about that, right?
Yes.
If you have an option, if you know how to really knock out or inhibit oncogene, do you like to do that?
Yeah.
Why?
So to prevent further proliferation.
Other three steps, right? So that's why alkylating drug or your cytotoxic drug, they actually acting on the kind of oncogenes, right? You are breaking the DNA of the infected cell. Correct or not? True?
Yes.
Okay, fine. So who can tell me what are the steps involved in carcinogenesis? Basic steps of carcinogenesis. What are the steps involved in carcinogenesis? If example, I'm talking about mutation. Mutation belongs to which steps? Initiation, transformation, progression, proliferation, where?
Initiation.
Initiation actually always should be your, now I'm coming to etiology of the cancer. You went to, X-ray department or you are taking X-ray and that stupid don't know which proper length should select for you and they have chosen a wrong length and it can cause damage to your DNA, right? Correct or not?
Yeah.
Okay. Have you ever heard papilloma virus?
HPV.
Yes.
Why they're known for?
Cervical carcinoma.
Yes, very good. You are saying that. Have you ever heard hepatitis B can convert to hepatocellular cancer?
Yes.
Yeah.
Did you ever heard smoking or nicotine can be cancerous to lungs?
Yes.
Okay, so initiators are actually your risk factors. So can we remove, like somebody, young lady married recently, and husband is very cheap kid buying cheap oral contraceptive pill. What do you think? What risk is waiting for this lady, young lady?
Ovarian cancer.
Breast cancers. Okay, so early young life exposure to the combined pill is a risk factor. It's not a risk factor, almost carcinogen nowadays for developing breast cancer. So initiator are actually your risk factors. Badalta.
Yeah.
So which one is easier? Advise your patient not to expose with the risk factor or you go for expensive chemotherapy?
Advice.
So once you go for chemotherapy, actually you are targeting which step, that is also important. So we said there are four important steps involved in carcinogenesis. That is, number one is initiation, right? So initiation, actually we're referring to risk factor, initiating factor. Am I correct?
Yes.
Yes.
Okay. If this initiating factor is too strong or too bad luck for the patient, this initiating factor can convert initiation to transformation, right?
Yeah.
So what happened during transformation? We do the mutation, change in the DNA sequence, right? A new varieties of cells going to generate. Do you remember the movie Spider-Man?
Yeah.
Yes.
After spider bite, what happened to Spider-Man?
DNA change.
Yes, you saw the strand change and it come up with the new characteristics, right?
Yes.
Yeah.
So that is actually after effect, always after a mutation. Okay, so mutation is actually changing, you are changing the basic or normal habitat cell to a new species. And what they can do, we don't know. Still, scientists are searching. But commonly they found a mutated cell, there is a rapid less growth hormone or growth factor stimulation, non-stop. Each time they're running cell cycle. If you're running cell cycle so often, what do you think? What will happen? Mitosis is more or less.
More.
If mitosis is more, cell number is more or less.
More.
Very good. So now you understand transformation. Transformation actually nothing but the mutation of the DNA strand, right?
Yeah.
Yeah. So chemotherapy normally where they target it?
Cell cycle.
Yes, this in this transformation phase. So after initiation, transformation, then progression. Progression means there will be switch of apoptosis, there will be switch on rapid cell cycle. It involves so many things, but just remember commonly you need a lot of blood supply, lot of glucose, and also you need a lot of growth hormone to proliferate a cancer. Three very important ingredients I'm telling. Number one is abundant blood supply or neovasculogenesis. Secondly, you need a lot of growth hormone or growth stimulating factor, and also you have to have a lot of cell cycle, and also you're switching off apoptosis. Only then cancer cell keep on doing progression. So initiation, transformation, progression, and proliferation, followed by metastasis.
Yes.
Who can tell me if there any student once campus is open and on, I will give you in cafe whatever food you want and how many plate you want. I don't mind. What is the role of E-cadherin into our body? Have you ever heard the protein E-cadherin? I think I have gone through your pathology slide. I saw some regeneration and also invasive and invasion metastasis. I saw that role of E-cadherin.
I think the tumor cells are adhere to each other via the E-cadherins.
Come again?
The tumor cells are adhered to each other via the E-cadherins, like it connects the tumor cells.
Yeah, it's like gluing or stapling the cells. All of us know epithelia or cells cannot stay without attaching with the basement membrane, right? We know it, right? Hello.
Yeah.
So a cell is a round, a round element. It's actually motile. In basement membrane is a muscle layer. So there is a one hook, one glue. That is actually E-cadherin. In cancer patient, they producing less E-cadherin. So there will be less, attraction or binding of cell into their own place. So cancer cell, they're removing all E-cadherins from the tissue. So they will be more mobile, they will be more easy to migrate. So kindly, if you have free time, you can study all this. Nowadays, a lot of research going on how to enhance concentration of E-cadherin, and that is the way actually you can reduce the metastasis. Do you know, I think I told somewhere, diabetic patient has a less chance of cancer. Have you heard it?
No.
Okay, so then you should search some journal. Metformin, anti-diabetic drug, is a very well known nowadays to reduce cancer aggressiveness and cancer progression. Do you know how?
No.
Okay, as I said, you need glucose, you need extra blood supply to progression of cancer, right?
Yeah.
But you are giving anti-diabetic drugs, which is reducing blood sugar level. And there is a study compared to normal human and diabetic person have the less chance or less incidence of cancer. So nowadays, a lot of study going on only simple metformin. So we target DNA, we target cell cycle, we target to how to increase concentration of caspase 3 and 8. Who can tell me the function of caspase 3 and caspase 8? Senior, why there is a pin drop silence? I'm asking who can tell me the function of caspase 8 and caspase 3? Is there anybody?
Protein cleavage.
Sorry?
Protein cleavage.
Oh, it's involved in apoptosis.
Very good. It's involved in apoptosis. Skijab. I show you something. Can you see my desktop?
No.
Still you cannot see my desktop. Now you can see my desktop.
Yes.
Yeah.
And you tell me. I would like to show you something. Mana, mana, mana. Can you see something?
Yes.
No, okay. Can you see 3 or 4 histone here? Histone, right?
Yeah.
Okay. So this is a real protein analysis. This is through one of my project. I'm doing it at this moment. Can you see here caspase 8?
Yeah.
Okay. Can you see annexin A2 here?
Yeah.
Okay. Kindly tell me the function of these 2 protein. Google it. Take 1 minute time. This is to me is like your the IRAT, GRAT, SLT, whatever. Tell me the function of caspase 8 and annexin 2 protein.
Doctor, it's annexin A2, right?
Hmm. Bulba, can you tell me?
Annexin A2 is involved in cell motility.
Cell motility or cell cycle? Something to do with the apoptosis. Can you find? Is there any other volunteer? Okay, or I help you to interpret. Actually, from where I came here, we said there are 4 steps in cancer and how to correlate that theoretical 4 steps into our in real life drug development and discovery. So we said cancer may can start with the initiation, transformation, progression, and progression and proliferation and metastasis. Am I correct?
Yes.
Okay. Now here, this is a real experiment happen. This portion you can see all from cancer cell, and this area happen after treatment. So typically a cancer cell you'll be seeing, if you find the function of histone, histones are always accelerating cell progression. It means the more histone you have, there will be more cancer progression. Supporting, you'll be seeing, see, DNA binding, transcription factor, RNA binding. So all are contributing to go for your cellular proliferation. But once you start treatment, in this cycle, you cannot see caspase 8, annexin 2, and extracellular matrix protein. It is not within the core. But after treatment, you can see the concentration of annexin 2 is higher, caspase 8 is also appearing. So what does it mean? If caspase 8 annexin 2 is there, we already know your cell started apoptosis. So apoptosis is good for cancer cell or not?
It's not good for cancer cell.
Hmm?
No, it's good. It's good.
It's good because cancer cell normally they stop caspase 8 secretion. Kanta. Have you got what it's saying?
Yeah.
So it means there is an echo. Can you switch off? So it means our anti-cancer drug therapy initiation, we cannot do anything until we just can advise patient not to take oral contraceptive pill, not to keep the constipation, not to smoke, all that. Initiation, we cannot do anything. Transformation, we have to target the genotoxic drug, which involves a lot of toxic effect, and it has some other outcome also. So at this moment, what I try to say, people are more working on anti-proliferation and also anti-metastatic. That is the message I try to give you. Have you got it?
Yes.
Yes. Yes.
Again, I'm telling theoretical part. So you have to prevent cell proliferation. How to do inhibit cell proliferation? How can you do that? If your experiment, if the product you are using, if they can increase caspase 8, is it suggestive you are increasing apoptosis?
Yes.
Caspase 3, different product can have different potentiality, but you have to know the whole caspase set of proteins. Panta. Is that clear? So I involve one of my students. You do research with a cancer patient, and he started. Example, you are choosing, grape seed, or you are choosing rambutan skin, and your study is showing without your rambutan there is no caspase, but when you added some concentration of rambutan's skin or peel, and you are finding caspase, do you want to make the student pass or fail?
Pass.
Very good. Why you want to make this student pass?
He managed to increase caspases.
Very good. What is the role of caspase here?
Apoptosis.
Very good. Apoptosis. You got another student with another product. Maybe he choose palm oil, and he found his treatment is reducing CDK, cyclin-dependent kinase. You want to make him pass or fail?
Pass.
Very good. What is the role of cyclin-dependent kinase?
For
Cell
regulate
cycle.
the cell cycle. Yeah.
Yes, cell cycle. So there are a lot of varieties of cyclin, CDK and cyclin-dependent kinases are there. D, E, K. So if you can block at least one also, it also can be a anti-cancer drug. So that's how it works. Just now I was telling about anti-diabetic drug metformin. It going to be in which part? Metastasis, apoptosis, or proliferation?
Proliferation.
Why? Because without sugar, actually, you are inhibiting neoangiogenesis. Do you know what is angiogenesis?
Yes.
New blood
Yes.
supply to the cancer.
Is there anybody who can tell me the function of TNF alpha? What is the role of TNF alpha? Tissue necrotizing factor alpha. What is the physiological role? Never mind, take your time.
Inflammatory cytokine.
Lagi? Anything to do with the blood vessels?
Which leads to apoptosis of cells.
Migration of fibroblasts.
Okay. No relation with the blood vessels?
It damages the blood vessels. Causes damage to blood vessels.
Damage, or sometime in some journal it's telling they helping to form new blood vessels. So there are some drug also they can inhibiting the concentration of TNF alpha. And I think probably from pathology, inflammation can convert to carcinogenesis, chronic inflammation. Granulomatous change can cause cancer, right?
Yeah.
Colorectal cancer is nothing but extension of chronic inflammation towards cancer. Okay, so that's why you have 4 steps to target 4 different phases of progression of the cancer. Can you tell me the poor outcome of cancer in which phase? Initiation, transformation, proliferation, or metastasis?
Metastasis.
Metastasis, yes. So again, our treatment is depending when we are receiving the patient. If it is still in dysplasia and initiation phase, it's easy. Transformation depend on the luck. If your patient is lucky enough, like for leukemia, lymphoma, we can cure properly. But if metastasize, we have very less option. So where patient is, depending on that, we have few options for treatment. But classically, what we do, firstly, we operate the site of tumor, followed by we give radiotherapy. After radiotherapy, we give the chemotherapy. So there are 3 mainstream option of treatment. We are in pharmacology, it doesn't mean I have to spend all hour on mechanism of anti-cancer drug, because we are in a real life situation. I really have to tell you from A to Z how we deal with a cancer patient, right? Every day your parents are shouting on you, take vegetable, you should take sayo. What do? When your father move, you throw it, right? How many of you do that? How many? Most of you, right? Yes or no?
No.
I don't believe it. So what happened if you take more vegetables? Naturally, you are getting so many active compound who can reduce the chance of your transformation or progression. Apart from that, what I'm saying, there are fixed 3 sets of treatments are there. Number 1, it must be surgery, right? You remove that portion of the tumor. I think many times you saw lady around 28, 29, they go for uterus operation. Have you ever heard?
Yes.
Yes. So what they do cut the part of the tumor occur in uterus. If not, it will involve fallopian tube and ovary. A unmarried lady at 29, 30, you cut the part of the uterus, fallopian tube and ovary. What danger you are bringing to her life? You understand it? Is going to measure her life. You can see one lady with a small mass into the breast, they go for total mastectomy. Correct or not?
Yes.
Yes. So the first rule, you have to operate the lesion area. It doesn't, I'm a pharmacologist, so that all the time I'll be talking about drug only is lie. So all the time, the first priority, the in a lesion area, disease area, you have to remove. Surgery is the first option, followed by radiotherapy at that particular area. So that if there any other infected cell, that gonna kill, followed by chemotherapy, because we are not sure whether with surgery we have removed 100% cell or not, or is it involved with the basement membrane or not, so that we give chemotherapy. So who can tell me what are the three mainstay treatments options you have for cancer?
Radiation therapy.
No, I didn't say radiation therapy number one.
Surgery.
And then
Yes.
chemotherapy, and then radiation therapy.
No, surgery, radiation, and chemotherapy. Because
Removal.
yes, because maybe all patient doesn't require chemotherapy. Maybe all patient cannot tolerate chemotherapy. So we follow the guideline from the textbook: surgery, radiotherapy, followed by the chemotherapy. Now, what is the standard rule for surgery and radiation? It is a localized tumor. Clear?
Clear.
If it is not localized, can you surgery somebody who already invasion and metastasis occur? Then you have to cut the all organs. Betul tak?
Yeah.
So I'm asking you, radiation, surgery and radiation for what type of tumor? Localized or metastasized?
Metastasis.
Localized.
Localized.
You said
Localized.
metastasized. Tidur ke? So localized tumor, the best option of treatment should be surgery and radiation.
Radiation.
Chemotherapy mostly for metastatic. That's why I said probably all doesn't need chemotherapy. Okay, so chemotherapy is mostly either micrometastasis or metastasis patient. I believe you can remember it. There are some cancer, it can be 100% curable. There are some cancer, prognosis is very bad. The tumor more bigger size is more good for the patient. Do you know, I think during the main class I said ovarian tumor, it can be a size of football, 18 centimeters. You know football, right?
Yes.
Yes.
Ovarian tumor, classically it can be big. Do you think it's good or bad?
It's good, probably.
It's good because it's a rapidly proliferating cell. So, leukemia, lymphoma also very rapidly proliferating cell, which is suitable for our chemotherapy. So, because of that character only, there are some cancers whose, success rate, curation rate is almost 100%. So, among them, actually, lymphoma, Hodgkin lymphoma, leukemia, and also Barrett lymphoma, I think. These are the disease 100% curable. Why? Because those cells follow rapid proliferation. However, only a 3 centimeter size colorectal cancer, even after chemotherapy, expected life duration is 6 months to 1 year. Whereas a lymphoma, leukemia patient can be 100% curable and they can lead a normal lifespan, 60, 70 years, doesn't matter. But a 3 centimeter colorectal cancer, a 2 to 3 centimeter pancreatic cancer is deadly. So it means there are some cancer who doesn't follow rapid proliferation theory. Clear? Vitulta?
Clear.
Yeah. So that's why when we choose anti-cancer drug, mostly we target for what type of cancer? Rapidly proliferating or slow-growing cancer?
Rapidly proliferating.
So that's why we saw in our community, in our medical life, some cancers are curable, some cancers are non-curable. So what is the secret? Some cancers are curable. How to explain? Some cancers are curable, like leukemia, lymphoma, Barrett esophagus, all that are curable. Why?
Because they're rapidly proliferating.
Yes. So if they are rapidly proliferating, what is the benefit for you?
they'll grow
Early
larger.
detection.
Okay.
Early detection. Ease of detection. I mean. Ease of detection.
Okay, no. I'll be going on. Tell me what are the phases of cell cycle involved? What are the steps involved in cell cycle?
Your G1 phase, your S phase, your G2 phase.
And your mitosis phase.
M phase. So a cell rapidly proliferating means cell cycle is more or less.
More.
So they're producing more cyclin or not?
Yes, more cyclin.
Then is my drug target is very easy. I'll choose a drug who can block S phase. I'll choose a drug who can block G1 phase. It's easy for me. Itu je. Faham tak?
Paham.
So that is the secret of hyperproliferation. It means in that person, or maybe you know the growth factor, right? Cell never go autonomous or alone any kind of regeneration. You need a stimulating factor. That stimulating factor is given by growth factor. Why I'm deadly against of taking oral contraceptive pill by a lady? Because those estrogen acting as a growth promoter. So if I give anti-androgen, either anti-testosterone or anti-estrogen, can I remove the factor responsible for cell cycle? I'm a bit, you guys don't understand the second messenger concept. Give me example of 3 second messenger.
Calcium, IP3, DAG.
These are all intracellular. Extracellularly? What are the first messenger?
Neurotransmitters, hormones.
Very good. So hormones, estrogen is a hormone?
Yes.
Yes.
Testosterone is a hormone?
Steroid hormone, yes.
So simply, can I block the first messenger? Can I do that?
Yes.
Yes.
So if I block first messenger, is there anybody who can activate second messenger?
No.
No.
So if there is no second messenger, can anybody initiate intercellular event?
No.
No.
So that's how, why 100% curable cancers are rapidly proliferating, because I can interfere with the first messenger, second messenger, and the machineries we need for progression of cell cycle. Can or not?
Yes.
Do you know for each cancer, chemotherapy is almost fixed? Like all men in the world, if they're having prostate cancer, you'll be knowing 3 or 4 chemotherapy cycle is required. Do you know that? Did I mention in the first class? Hello?
Maybe you did, but we don't remember, doctor.
Okay. So what I'm saying, anti-cancer drug, they follow first order kinetics. So first order kinetics means it may be for elimination, or it may be on the capability of killing bacteria or cancer cell. It means each dose capable of inhibiting fixed percentage. So example, if you choose a chemotherapy drug who can kill 25% cancer cell. So to kill 100% cancer cell, how many doses you need? First dose, yes. First dose always going to inhibit 25%. So if 25% you need 4 cycle, right?
Yes.
You've got one anti-cancer drug whose capability to inhibit 10% of cancer drug. So how many cycle you need?
10 cycles.
So it will be fixed. So after first cycle, we know actually whether the patient condition going to improve or not. Why? Cancer drug on rapidly proliferating cell, they follow first order kinetics. So in first order kinetics, is not the number, percentage of inhibition is important. So that's how we can calculate the the total number of cycle responsible for anti-cancer therapy. Clear?
Clear, doctor.
Okay. So is it justified for us to target cell cycle for anti-cancer drug?
Yes.
Okay. So should you study what are the S phase specific anti-cancer drug, G1 phase specific drug, and so on?
Yes, we should.
So if you remember from my slide, classify anti-cancer drug, nama sahaja, only name, you will get one SBQ question. So what are the S phase specific anti-cancer drug, G1 phase specific anti-cancer drug? Within top 2 or 3 drug example is enough. So S phase blocker, 2 drugs. G1 phase blocker, 2 drugs. G2 phase blocker, 2 drugs. M phase 1 or 2 drugs. So is it okay with you?
Yes, doctor.
Does it have the in future also prospect for you when you go to year 3?
Yes.
Yeah.
Now, anybody asking you, I'm a stranger, I'm year 3 teacher for you. I'll be asking you, tell me the very important classification, or tell me 2 drugs can be used for for cancer therapy. What are those?
Methotrexate.
Again, you're going for a specific drug. If I ask you classify generally, if you ask me, I'll be telling, I will try to develop a drug who can actually cause apoptosis or can prevent cell cycle. And you'll be surprised to know till today, a proper apoptotic inducing drug is not authorized by FDA. It is so complex mechanism. Just now I show you caspase 8 and annexin 2, right?
Yeah.
Yeah.
So I know one product who can increase caspase in prostate cancer. I already got the results and everything with me. So why I didn't choose for cell cycle? Because it's already been established. So many drugs are available. What is the gap? Remember the drug discovery and development, I said you have to understand the disease pathophysiology, remember?
Yes.
So can we find in cancer, there are 2 things happening, increase cell cycle, decrease apoptosis. Pranta. Correct?
Yes, doctor.
So now I want to develop cancer means, anti-cancer drug means I have to stop cell cycle and I have to enhance or increase apoptosis. But you even textbook also, you go and study Katzong, you cannot find 2 drugs who can induce apoptosis in your body. So if you clever enough, lucky enough, if you develop one drug who can increase your caspase 3 or caspase 8, one day you might be appearing in textbook. But what I try to say, you are understanding disease pathophysiology. Am I correct?
Yes.
Okay. Now you got another drug or some antibiotic you saw. They are attacking bacteria, fungus, and they are inhibiting or destroying the DNA synthesis. Did you remember? Can you example any drug you studied already in antibiotic who can inhibit bacterial DNA synthesis?
Sulfonamide.
Sulfonamide, very good. Anything else? Very good.
Trimethoprim.
Okay, trimethoprim is the
Fluoroquinolones.
fluoroquinolones, very good. So you know already these are the drug who preventing topoisomerase 2 and 4 and you are inhibiting DNA synthesis. Same way, if you can we cannot inhibit DNA synthesis because cancer cell already there, but we have to do the toxicity, destroy the strands of DNA. Can it be a target? Can it be a target?
Yes.
Yes, exactly. It can be. So genotoxic drug, cytotoxic drug, methotrexate actually belongs to that group. So we call them antimetabolites or genotoxic drug. So this is also another group of drug already present into the market. So most of the cancer nowadays we treat with the 2 kind of drug, genotoxic drug, because they cause toxicity into the DNA, genetics, right? And also cell cycle arresting drug. Who can repeat me? What are the 2 common variety drug you're using for cancer? What are the present existing 2 classes of drug available for cancer chemotherapy? Who can tell me?
Cell cycle specific agents.
Cell cycle specific arresting drug. Very good. Cell cycle arresting drug. Lagi?
Genotoxic.
Genotoxic or anti-metabolite drug, right? Panta. Okay, now Nurul Iza. Nurul Iza. How many Nurul Iza there? I don't know, but I can see only one. Is there Nurul Iza? Yes, Nurul. Can you hear me? So, should we find this drug who can enhance our apoptosis? Should we find it?
Yes, definitely.
Yes, but that is under investigation. A lot of research going on. Maybe when you become a doctor, it will be already there. There will be some drug who can increase apoptosis of cancer cell. So we have three way of actually targeting cancer. In fact, four. Number one, cell cycle arrest. Number two, genotoxic or cytotoxicity. We can enhance or increase apoptosis, and we can prevent metastasis. Clear? So metformin, anti-diabetic drug, actually acting on an anti-invasive and anti-metastatic area because they prevent the vascularization or new vessels formation. So do you think chemotherapy is not at all toxic for your body? You agree with me? Do you agree?
No.
It is very toxic for our body, right? So in our body, apart from cancer also, there are some other cells having rapidly proliferating. Most of the cancer patient you see, they don't have any hair involved because our hair follicle also rapidly proliferating. So if we choose a drug acting on rapid proliferation of cell cycle, we'll be seeing alopecia. We'll be seeing a lot of diarrhea because colitis will be occurring there. They will have the peptic ulcer. So what I try to say, there is a formula I have given in the previous slide. There are some common unavoidable adverse effects like vomiting, rashes, okay, alopecia. So that please go refer back. No point of teaching that line by line now. So please go back to this adverse effect and it will give you one SBAQ question. Immediate delay adverse effect of anti-cancer drug. And when you go for delayed anti-cancer drug, you will find one table drug-specific adverse effect. So if you read that drug-specific adverse effect, definitely you'll get another SBAQ. So I already find out, I think 4 questions I have said from anti-cancer drug, but you have to really discover. I already telling you study of classification of cell cycle specific drug, study of immediate and delayed adverse effects of anti-cancer drug, and there was one table drug-specific adverse effect. And regarding immunopharmacology, I think during this endocrine block also, I'm going to take class on 9th, and from there also you'll get one questions there, because at your level, no point of teaching very advanced drugs, whereas the very basic one, steroid, commonly used to inhibit our immunity. Why? Because sometimes you remember myasthenia gravis?
Yeah.
What was happened in myasthenia gravis? Is it immunological disorder?
Yes. Autoimmune disease.
Autoimmune of the receptor.
It means in that patient, body immune system is hyperactivated, right?
Yes.
Yeah, there are so many other diseases there where invariably we have to use immune suppressive drug. Okay, it may be an organ transplantation, it may be because of some autoimmune diseases, but steroid is a very classical drug to use for immunosuppression. At your level, only steroid, you just remember that. Steroid as an immunosuppressant.
Doctor, question, are people with autoimmune diseases more likely to develop cancer?
No, actually two different topic. The cancer has, but some only chronic inflammation, not directly into the cancer, but it has role in angiogenesis because you need some inflammatory mediators to actually enhance neoangiogenesis. And also chronic inflammation has a role in cancer progression. So chronic inflammation cannot occur without migration of your chemokines. Okay.
So even if they take immunosuppressants?
It depends actually. I normally practically I didn't saw.
Okay, thank you.
I didn't saw. But it happened during the initiation phase. Okay. So because our major problem with cancer treatment when patient is reporting to the doctor, our therapy is depending on that. Okay, so I go back because the one of the objective with this revision session to find out the questions and to understand the topic and answer into the exam. I teach so good, so called, and in the exam you like seeing the star and moon. No point. You are studying not only for knowledge but also for good score into the exam, and you feel comfortable when there will be exam. So please find the question and answer from there, from classification of anti-cancer drug, adverse effect of anti-cancer drug, and only steroid sahaja. And there will be one question from your basic understanding concept. If you faham the topic, you can able to answer. I think saying so, thank you very much, all of you, for your precious time spending with me with the revision classes. So can I open the session for Q&A?
Yeah, doctor, I have a question on how do you say that metformin is an anti-cancerous drug? Because if correct me if I'm wrong, metformin increases your insulin receptor sensitivity so that your insulin responds better, right? So if metformin helps with increased blood glucose uptake, isn't that actually helping the tumor cells to grow?
Kindly you refer back to this kind of study, normal people and diabetic people with insulin therapy who having more cancer. It's a very new topic. It's a new, because I said glucose you need for angiogenesis. So what they found, if you give insulin, so that sugar will be not into the blood, sugar will be going inside the tissue. Faham?
Oh, okay.
There are a lot of new studies are coming, how to combat less sugar, less proliferation, simple. So how to get less sugar? If we giving either metformin or we are giving metformin actually especially very specific. Nowadays, lot of study and research going on. I think somewhere we should start some topic from journals, like with COVID, so many things are going on, but we are too busy and stick with our very prescribed form of curriculum. But as I said, a lot of study going on how to enhance apoptosis in cancer. You will not find it in textbook, but in research area, it's almost going to be established. Nobody will teach you entry androgen for cancer therapy, because breast cancer straight, the most occurrence of breast cancer is the young lady. Doctors and surgeons, they try their level best with the conservative therapy first, with anti-androgen and anti-cancer. But how much we are teaching you, how much we try to correlate the excess hormone, how can influence your cancer progression and cancer generation. So that's why fast messenger inhibition, it has a very crucial role in cancer initiation. It can be hormone, it can be neurotransmitter, or it can be exogenous drugs. So answer to your question, please try to find out role of metformin in cancer prevention. You'll be seeing good company, very good publisher journal, how many papers they have. And if you want to do a comparative study, normal person and diabetic person who having more cancers. The clue, you are dealing with the sugar concentration into the blood. Faham?
Right, got it. Will do, doctor.
Yeah. Are there any question?
Doctor, can we group blocking first messenger and second messenger under blocking cell cycle?
Yes, because autonomicity, cancer cells are autonomous in nature. This autonomicity depend on two factors actually, first and second messengers. Estrogen in breast cancer act as a growth promoter, which is a hormone and who belongs to first messenger system. Fanta. Okay.
Yes, thank you.
Yeah, so I will keep the screenshot of this attendance. How many international students are here? How many? Do they know about this class? They should know, right?
Yeah, I
Yeah.
reminded them.
It means they know everything or they don't know anything. Only Jana is Jana, how many international students are here?
I'm really not sure, doctor, but there's me and Sarah from the questions that I've been asking.
Because after that, if result is not good, we lecturer are to blame. What to do? Okay, guys. Thank you so much. Other thing before exam, 19 June, right?
Yes.
Okay.
Yeah.
Probably I don't mind to maybe 2 hour, 3 hours exam overview. How to really the question system work, from where you should give more emphasis, which concept you should really give preference. Okay, exam going to be online, right?
Yes.
Yeah.
Okay. So you are going to sit for exam in Zoom or Team.
Not sure, doctor.
Yeah,
Today we first
Zoom.
try with Zoom.
Okay, there. Because I don't know anything. All CUSMS, I'm just sharing something is recorded. Actually, I don't care. It's recorded, don't record also, I don't mind. There is a one lecture, student and lecturer in your WhatsApp group, right?
Yeah.
Did you find my name there?
Oh, WhatsApp group?
Yes.
Oh no.
Why?
It's for the
No. Normally that any other blog you ever saw my name?
Not so far, doctor.
In pharmacology also this group was existing, right? During pharmacoblog,
yeah.
my name was there.
No.
It's okay. Allah is there and He will decide for everything. At least you guys know what is my contribution, and I really care for your respect and acknowledgement. What others are doing, I really give a damn on that, because I know what I do and I know how I do. But sometimes, yeah, true, it hurt, but it's okay.
We appreciate you a lot, doctor. Thank you very much.
Yeah, that's yeah, batch after batch, year after year. That is my inspiration actually. That is my only inspiration. So that's why where you are giving exam, what happening actually, I don't know. I just know if I have a class, I take it. If no, I just do my work. Rest, I leave all of you are mature on all your judgment, and I leave to Allah as well. I'm sorry. I'm saying because suddenly I came to know about all this happening because I never know. We are paying a lot of money for Microsoft Team, and as far I know, this is very secure. Nobody can hack. So when a student asked me, I suddenly don't know. They said no, it's already in the WhatsApp group. So I become stupid. I don't belong to any group. It's okay. My happiness, if you guys are happy with my class, your value, your respect is more important than any other thing. Okay?
Okay, doctor, we love your class. Thank you for teaching us. You are very sincere. Thank you.
It's okay. I try to be just justify your tuition fee. That's all. Don't think I'm good, bad is very relative matter. There is a no fixed definition of good or bad. If you are not belongs to certain group, you might be bad. If you don't judge people, you might be bad. If you don't involve too much with the student personal matter, you are bad. So it's okay. Good and bad is a very relative term. But I'm very cautiously try to make justification with your tuition fee. And some more, all are going online and whatever, there is no discount for you in tuition fee, but as much as possible from my side, our end, we can contribute. I don't feel I'm very special somebody or important enough even to be in official group. It's okay. It's okay. I wish they can feel for all of you and can do all of you more than that, more than me. Because even pharmaco block also I didn't include it. Endocrine others are teaching. I'm not going to teach, but I'll be seeing how many of them actually teaching better than me in endocrine block. That is also true. Okay, if you stay more, I'll be more emotional. Leave it. Okay, salam, huh? Take care, guys.
Sorry, doctor.
Doctor, thank you so much.
Thank
Really
you,
enjoy your
doctor.
class.
Okay, take care. Bye.
Thank you.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you,
Thank you,
doctor.
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 Thank you so
Thank you,
much,
doctor.
UOC drama.